Hello, everyone. My name is Donnie Harris. I'm a social worker and care services coordinator covering Queens and Nassau County. I would like to welcome you to our session today, Palliative Care as an extra layer of support for people living with ALS. Palliative medicine is a specialty focused on supporting people living with serious illness and their caregivers and emphasizes quality of life. In this session today, we'll discuss the role of palliative medicine as a part of the ALS care team. Specifically, we will discuss symptom management, exploring coping strategies, and planning ahead for the future. I would like to introduce Dr. Carolyn Crooms. She's an assistant professor in the Department of Neurology and Hospice and Palliative Medicine at the Icahn School of Medicine at Mount Sinai. She has been a part of the Mount Sinai's multidisciplinary ALS clinic team since 2019, providing palliative care expertise. Without further ado, Dr. Crooms, take it away.
Thank you so much. I'll just take a moment, share my screen here. Okay, hopefully everybody can see that. Let me know if you can't. Thank you so much for having me. It's always an honor. I really appreciate the opportunity to talk with you today about palliative care in ALS, which, as we'll get into, I really see as an extra layer of support for people who are living with ALS and their families. Let's see if I can advance this. There we go. I don't have any disclosures relevant to this talk. So I'll tell you a little bit about my objectives for today. So the first, maybe third of my time, I'll talk really about what palliative care is, why one might want to seek palliative care services, and kind of what, when, and where that involves. And then the second half to two-thirds, we'll talk about some of the specific things that people often think about or that I particularly do in our clinic in discussing serious illness conversations and advanced care planning, and then also talking about hospice and its role in ALS, which, as we'll hear, if you haven't already, that is different from palliative care. Hospice is different from palliative care, but often confused. All right, so what is palliative care? Here's a long definition that I won't read in its entirety, but basically it's specialized care for people who are living with a serious illness with the goal of providing relief from both the symptoms and the stressors, with the ultimate goal of improving quality of life for both the patient and the family. And it's based on the needs of the patient, not on prognosis or life expectancy. It can be for people at any age and any stage in a serious illness, including from the time of diagnosis. So I'll speak now for a little bit about what that really means in practice. And I really like this quote from palliative care colleague of mine who says that I'm there to celebrate with you when things go well, and I'm there to support you when things are more difficult. I think often when people have heard of palliative care, they're really thinking about the difficult times. And I think we have a broader role to play than that in helping people to live well with their illness. So why one seek palliative care? There are a number of different benefits. A lot of them have really been shown in the advanced cancer population and not so much in neurologic serious illness such as ALS. But we think that a lot of the benefits translate, and there's been a lot of increasing research in the neuropalliative space, which is what I do to understand how palliative care can be helpful in neurologic disease as well. For one thing, palliative care can improve symptom control and quality of life by really focusing on screening for symptoms to identify them early, and then treating them very aggressively without kind of needing to focus on also what are we doing for the underlying disease. Can improve patient and family or care partner satisfaction with care, and it can help ensure patients get the kind of care that they value, which might not be the same for everyone. And we'll talk more about that in the section on serious illness conversations and advanced care. Palliative care should really be part of the team. So this is a nice diagram showing the centering of a person with ALS at the core of this multidisciplinary team that includes their family, caregivers, friends, and community, as well as the medical team, of which the palliative care team should be a part. Palliative care really should be a team sport. Unfortunately, it isn't always, especially in the outpatient setting. Like if you're going to a multidisciplinary clinic, most do not have a palliative care clinician. Ours only has me as a physician. But in a perfect world, palliative care should be interdisciplinary with not only a physician, but also a nurse practitioner, potentially nurses, social workers, and spiritual care providers or chaplains, because we recognize that there's different types of expertise from all those different disciplines that may be able to help with different aspects of living with a serious illness. And I should say that typically in the inpatient setting, if someone is hospitalized and they receive a palliative care consult, usually there will be a larger team in that context in most hospitals. So what are some of the things that palliative care actually does? There's actually 8 different domains of palliative care, which might be addressed to a varying extent depending on where somebody's needs are and what the structure of care is. So care coordination is one. That's that interdisciplinary care I talked about. And also helping people to come up with and understand the plan for how, where, and by whom their care will be delivered. So really a big part of palliative care is working with those other team members. So people have heard of, going to palliative care as like a separate process. It really shouldn't be. Palliative care clinicians are trained to coordinate with someone's other medical team members. Management of physical and psychological symptoms is a big part of what we're trained on. Providing social support, which can include support for caregivers, identifying different social supports that may be helpful, and then also just exploring sources of coping and joy. That's a really big part, I think, of what I do and kind of building relationships with people who have ALS as well as their families. Spiritual support and culturally competent care. So recognizing that when someone is living with a serious illness, the cultural background of that person and potentially their family can really play a role in how they think about their illness and the decisions that they might make and the experience that they have. Advanced care planning, which kind of falls into the domain of ethical and legal issues. So we'll talk more about that later, but engaging in shared decision making, thinking about the goals of a person's care, as well as making sure that we're understanding kind of the regulatory and legal aspects of palliative care that involve surrogacy, like who make decisions if someone's not able to communicate their own wishes, and completing advance directives, that sort of thing. So we'll talk more about that later. And then for some people, and in some contexts, end-of-life care is also a part of palliative care. Most often that includes developing a care plan for the end of life, which might include hospice referrals for the appropriate person. When should these things happen? It used to be that people would sort of live in this space of, really curative, life-prolonging, disease-directed therapy for most of their time living with a serious illness. And then when they reached the end of their life, or what thought might be the end of their life, they would say, okay, now let's do palliative care. But that has really changed. And so now if people are just bringing up the idea of referring to palliative care and involving palliative care, it should not mean that. So people are receiving that curative, life-prolonging therapy, taking really is all Radicava, enrolling in clinical trials, and can also receive palliative care as that extra layer of support, because we recognize that the benefits are greatest when palliative care is involved early on, and because, as I said, these other team members have issues that they're focusing on that are maybe specific to ALS. So maybe we're assessing different motor deficits that have developed and are identifying different durable medical equipment or resources that will help to mitigate that issue. And that is taking up the time. So we're not necessarily talking about, what's your day-to-day experience of this? How can we help you to live better and to do the things that that are most important to you? And then also potentially doing some additional symptom management that might not come up when we're screening for the most common symptoms, ALS. So there's a time element to it. Often palliative care is involved when there's more of a time of crisis. So if somebody is admitted to the hospital, for example, then palliative care has additional expertise in kind of navigating decision making in those contexts. And that's another situation where we might be involved and can be helpful. I sort of keep coming back to this fear that sometimes people have about palliative care, a misconception that this is end of life care, and that if it's brought up, that that's an indication that someone is at the end of their life. And I really would like to help dispel that that notion. So I think of this as sort of meeting somebody where they are. This is a graph from or a figure from a publication in the cancer literature. So this is from one of the original clinical trials that showed that early palliative care within weeks of diagnosis with advanced cancers can help people to have improved quality of life. And this is that trial was back in 2010, and then they did this analysis in 2018 to kind of look at in the visits that people had with palliative care from the first to the last, what were the issues that were being addressed by palliative care? And each of these colored lines shows, what they were doing in the first visit, second, etc., and then on to the last. And the topics that they addressed were building rapport, kind of having a relationship with patients and with their families, addressing symptoms. That was something that was really consistent throughout. Same with coping. And then the things that people maybe associate more with that end of life involvement, advanced care planning and treatment decisions were pretty low early on and kind of built over time as they became more relevant. So that those benefits really come from having more time to do these top things that hopefully are not stressful for people and provide more benefit. And then sort of as time progresses and things are more, it's more important to be kind of talking about that bigger picture and planning for the future, then we might start to bring that stuff up. So my approach, which I should say is really developed from my about 6 years of experience now, and not necessarily because there's a whole lot to guide practice, although hopefully that's changing as more research is done. But just to give you a sense of what I do based on my experience now. So this is these arrows kind of indicate time. If you have diagnosis, over here on the left, and then progressing through the illness course here. When I meet people early on, my main focus is just checking in about how they're doing, how they're processing the information about the diagnosis, and kind of navigating that early period. And we might often try to identify a healthcare proxy or somebody who would be able to speak on behalf of the individual with ALS if they weren't able to communicate those wishes, their own wishes. And then as time goes on, we might kind of explore goals and values, which I'll talk a little bit more about in just a moment, what I really mean by that, but kind of getting a sense of, who are you as a person? What's important to you? What's important to your family? Not necessarily tying that to any specific decisions, but just getting a sense of, what's most important so that our team can bear that in mind as we're helping to put together a care plan. Then we might sort of be talking more about anticipatory guidance, maybe things are changing a little bit, and what do we expect in the next steps if that's something that a person or their family wants to hear, which may not be the case for everybody, but we always ask. And then when they become relevant, then I'll help support people through making care decisions like whether or not they want to have have a feeding tube placed or a tracheostomy placed or that type of thing. And throughout all of this, I really try to also talk about how people are coping. Are there other care needs that they have? I see all of our patients along with our social worker, Bonnie Simmons, in order to sort of connect those different aspects of well-being that are addressed by a social worker and addressed by a palliative care clinician. And so that's really our our way of capturing that interdisciplinary aspect of palliative care, which I think I find to be very meaningful. I have symptom management in parentheses here because it has just shaken out in our practice that most often a lot of the symptom management, like medication prescribing and that sort of thing, is done by the primary neuromuscular neurologists. And I don't do as much of it, although there certainly are times when it comes up, especially if somebody has more complicated pain management needs, and we're thinking about prescribing opioids potentially, since that's something that tends to fall more into the palliative care expertise. Okay, so where does palliative care happen? This is a very complex diagram, and I won't go into it in too much depth. I think my main takeaway with it is really that it is sort of complicated, but there are a lot of different ways that one might access palliative care. So here in the middle, we sort of have the outpatient clinic, which could be standalone, meaning someone says, you know, gosh, we think you'd really benefit from a palliative care referral. We're going to refer you to this team that's in a separate physical location, maybe they have their own separate practice, or an embedded practice, which is what I do, meaning that when people come for their ALS clinic visit, they see me and Vane, our social worker, in addition to seeing, you know, their neuromuscular neurologist, their physical therapist, respiratory therapist, etc. When somebody is admitted to the hospital, they may be seen by a palliative care consult team, or in some contexts, there may be a palliative care unit that they could be transferred to. And then in the community, for somebody who is not at home, there is often palliative care in different types of facilities, whether that's a skilled nursing facility or a long-term care facility. And then we haven't really talked about hospice yet. That'll come at the end. Hospice care is usually at home, but some circumstances can be done in a facility. So depending on what somebody's needs are, there are a lot of different ways that one might access palliative care. Typically comes with a referral from, could be any clinician, whether that's the neurologist, whether it's a primary care doctor or someone in the hospital. Can come from a variety of different sources, and should be covered by insurance. So it can also be requested by patients or family members if they say, you know, this would really, I think, be helpful for me. I'd like to have another perspective on this symptom, or planning for the future. Okay, so I know I'm talking quickly here, but there's sort of a lot of ground to cover, and hopefully we'll have lots of time for questions here. So moving on to serious illness conversations and advanced care planning. This is, as I said, a really big part of what I do, in part because I am seeing people in a context where they're having a lot of their symptoms addressed by other members of the care team. So a big part of what I do is to kind of say, you know, are we talking about the big picture? Are we talking about how you're feeling and coping? And what does it all mean as far as making decisions? So when I talk about serious illness conversations, these are discussions about a person's personal goals and values and preferences for medical care. It's important that we have these conversations because one size doesn't fit all. People make very different decisions faced with the same information. But in order to make those decisions, you need to have the information about what's going on, what would we expect, you know, what are we expecting in the next weeks, months, years, and what's important in that context. Who would you want to speak for you in a crisis? And then in the context of talking about all of that, you know, what's happening emotionally? That's not always something that comes up, unfortunately, in our medical system. But certainly we recognize that that is an important part of the experience with any serious illness, and being able to have some space to process that is really important. So any good serious illness conversation should include, being able to kind of talk about the processing aspect of that. And this is something that's been studied a lot in palliative care. It can really improve communication with the team, with loved ones, in order to help support those conversations, which can be so hard to have with our families or friends or other loved ones. And it also helps the team to provide better care. We can't do what's most important to somebody if we don't know what that is. So being able to come up with a care plan that's based on person is and what's most important to them is a really big part of having these conversations. I kind of like to think of it as moving away from the menu. In bad old days, medicine was all about, well, here's what we're going to do, and you don't like it, too bad. This is, the doctor says this is what's going to happen. And then in more recent years, we've kind of moved to this menu approach where, we might say, well, here are the risks and benefits of this option and this option and this option, you choose, which is certainly an improvement over the paternalistic approach. But it doesn't necessarily take into account the things that might be important to you personally. Because when we talk about, as physicians or nurse practitioners or others, as clinicians, what the risks and benefits are, it might not necessarily touch on the things that are actually important to the person who's hearing about them. So serious illness conversations should really get at the more personal aspects of the care decision. And I'll talk about what that actually looks like in just a minute. So rather than doing that menu thing, what we focus on is your goals and values, number one, which are really the issues that are important to you as a person. And those are typically things that don't change over time, although how much you prioritize different goals and values you might have often does change. So maybe for somebody, it's living as long as possible. Maybe it's remaining at home, spending time with family and friends, being independent, maintaining comfort. These are the ones that come up a lot, but there's so many more, and being able to articulate what's most important, really valuable, making these decisions. And then preferences are different. That's the choices that you make about your medical care. So the goals and values really don't have anything to do with the specific treatments that you might be receiving, but the preferences do. So that's where you're deciding, am I going to have a tracheostomy placed? Am I enrolling in a clinical trial? And am I enrolling in hospice? Those are some of the really big preferences that one might have, but they certainly can apply to smaller things as well. So a high quality serious illness conversation should really elicit the goals and values, make sure that you have the up-to-date information about your illness, if you would like to have them, and then to help align the treatment plan with them, to kind of say, based on what you're sharing with me about it being really important to be, as independent as possible, this particular treatment is probably not going to contribute to that, but this other option will in this way. And so that way we're really taking into account, what's most important to you in that treatment. So in practice, here's just a sort of contrasting slide using the example of a tracheostomy. So the usual approach might be to say, well, here's why we're having this conversation. The non-invasive ventilator is not providing sufficient respiratory support at this point. So now you kind of have that information. And then here are treatment options. We could place an elective tracheostomy now to say, we know that this is going to come up soon. Let's place tracheostomy. Maybe we wait and see what happens and kind of let it be an emergency decision, or potentially enroll in hospice and continue the non-invasive ventilator and aggressive symptom management. So that would kind of be the first approach. The palliative care approach, you still get the medical update. Then we talk a little bit more about, how does it feel to hear that? And, what are you thinking about when that comes up? Because we know it's a really big deal. And it's hard to move on to the decision-making step when you haven't processed getting that difficult. And then we'd say, okay, well, given that knowledge, what feels most important to you in the next, say, days to weeks? And you bring up all types of different things, um, including, some of the different goals and values we talked about on the previous page. Maybe you're readjusting priorities based on that new information. And then from there, we'll discuss how each option could align with those stated goals. It might result in a recommendation, which people are certainly free to accept or reject. And also, it might be that someone is very clear right off the bat they don't need a recommendation, or they know exactly what they want, or they don't want one. But the main distinction here is that we're really saying, okay, like, what does it really mean to be having this conversation, and what's going through your mind, what is your experience as the person who is living with this illness and making this decision, or the family of that person, and then to be able to come up with a plan that takes into account those deeper issues. So when we're making a treatment decision, there's a number of different things, and I've listed some of the top decisions that people might be faced with when living with ALS, being whether or not to take or continue or stop ALS medications such as riluzole or radicava, having trials, having a feeding tube or tracheostomy placed, in hospice, and decisions about code status like cardiac resuscitation is really what by that. So in general, as we're making these treatment decisions, even if palliative care is not involved, what we really are trying to, what we really want to address are, what is the treatment? What does it entail? What are the benefits for you? Kind of what will it achieve? What will things look like? Pursue a particular path? What are the risks? And then also, how does it contribute to meeting your goals? So that's something that I think another point to make about serious illness conversations is that ideally these are really longitudinal. This is something for me that, it can be so heavy for people. It's very important, but also very heavy. And so having bits and pieces of the conversation over time can make it a little bit more manageable. So we're not necessarily going from, we've never talked about any of this to actually things are really not going very well right now. And we should have this big conversation about, having a tracheostomy placed potentially in the next few days or weeks. So being able to navigate that conversation over time and kind of build from stuff that's, maybe less daunting to some of the bigger decisions, valuable. So when we've already had these conversations, it can be helpful to record somebody's wishes in the form of an advance directive. This is something that people might be more familiar with. Again, we're sort of moving from just having an advance directive, which is like a legal document that records your wishes, to having serious illness conversations that are a little bit more deep. And then from there, you might complete an advance directive in order to make sure that things are recorded, and to try to be able to show what you've expressed in a way that can be shared across medical settings. You can bring it, to the hospital if need be, to different doctors, to share it with family members, etc. So a healthcare proxy or durable power of attorney for healthcare is one example of an advance directive that we really encourage everybody to have. I just want to highlight here that durable power of attorney for finances is not the same, and so you do want to make sure that you have, if you're completing that sort of document. A healthcare proxy is just for healthcare, so that would be a separate document. A living will, we'll talk about a little bit, and then medical orders for life-sustaining treatment, or in some states it's called physician orders for life-sustaining treatment. So I'll go through each of those kind of briefly. The healthcare proxy is probably the most familiar to folks, so I will not go to great depth about it. But essentially, the healthcare proxy is a legal document that says, this is the person, or in New York, up to 2 people could make decisions on my behalf if I were not able to make them or voice them. So it's important to note that designating a healthcare proxy does not take away your right to decision making, as long as a person is able to communicate their wishes. It doesn't have to be verbally. You can write them, text to speech. If you have an eye gaze, you can certainly write them that way, even like yes, no. For people who have verbal communication impairment. Under all of those circumstances, the patient is the one who makes their own decisions. But if for some reason that's not possible, it's a good idea to designate a healthcare proxy. The reason being, there's a few reasons. One is that way you can choose somebody who really knows your wishes and say what you say, because it's not always the case that everybody would be aware of what you want or what you would choose in a given situation. And so you want to be able to say, this is the person who's going to make those decisions. We should have conversations about what that would look like. The other reason, and this is particular to the state of New York, but also true in some other states, many other states, there is a law that states the order of surrogate decision making. So let's say I'm somebody who is married. My spouse or my long-term partner would be my legal surrogate if I weren't able to make decisions. If I don't have a spouse or a significant life partner, then my adult children would be next in line. Well, let's say I have many children and they all have different perspectives. Maybe there's one child who's been my caregiver, who we've had lots of conversations about what I would want, and I haven't designated that person as my healthcare proxy. Now, if it comes up that I'm not able to make my own decisions, all children have to be consulted and have equal decision-making power. So they all have to make the decision together. So if there's a situation where the person who is legally your healthcare agent, or maybe there's multiple people that would be your legal surrogate decision maker in the absence of a healthcare proxy, it really makes a big difference in terms of making sure that you're receiving the care you want to have designated somebody in advance. So that is something that we really encourage folks to do. It's easy to complete. You can get it online just by searching New York State Healthcare Proxy. It does not have to be witnessed or notarized. It does have to be witnessed. It doesn't have to be notarized. As long as you have 2 witnesses who are 18 or older and are not the patient or the healthcare proxies, it's valid. So really encourage folks to complete one of these. People who have an illness or don't have an illness, everybody should really have one, every adult, and helpful for the proxies to have copies of the document. Living wills, there are a lot of different ones. A lot of the time people will, go to a lawyer and sort of fill out a document that person has. Lots of different examples of this. The 5 wishes is just one that I've showed here that covers 5 different topics. Again, the healthcare proxy, types of medical treatment, priorities for being comfortable, how to be treated, and then what loved ones to know. And you can see that they give a number of different examples of things that might be important to a person that you can cross out if you don't agree with them or keep them in do. So that can be a little bit more in depth as far as providing wishes for a circumstance in which you're not able to communicate. Medical orders for life-sustaining treatment are really for specific medical decisions that somebody might have made. This is really only recommended for people who have specific types of care that they do not want to receive. So if you're somebody who says, I would really want to have any type of medical treatment that could prolong my life or potentially benefit me in other ways, there's really no limitations to the types of medical care that I want to receive, then this probably is not a form that you would need to have. It covers a whole bunch of different medical decisions somebody might make, which I won't go into great detail, but the two kind of big ones that it covers are cardiac resuscitation and different types of respiratory support, including intubation, like temporary intubation with a breathing tube connected to a ventilator, or long-term mechanical ventilation with a tracheostomy. And the reason to fill this out is if you're somebody who says, it's important to me that I not, for example, have cardiac resuscitation. This is a form that is signed by a physician or a nurse practitioner to document that that conversation's been had and that these are your wishes, or either expressed by the patient or by their healthcare proxy or legal surrogate. Under the circumstances, the patient's not able to communicate wishes. And that way, if, for example, a cardiac arrest happens at home, call 911. They are, in most cases, going to attempt resuscitation. They feel it's indicated, unless this form is present. So even if there's a healthcare proxy, that person cannot say, no, Carolyn did not want to have cardiac resuscitation, please don't do it. In most cases, unless this form is present and available to the paramedics, they will need to attempt resuscitation. So for people who have strong feelings about that, this can be a useful document to have. And then this just shows the second page of the form, which has, in New York, which has a number of other different treatment options like feeding tubes and antibiotics and dialysis. Okay, in the last 7-ish minutes, I'll talk a little bit about hospice and how it differs from palliative care and what it really is. So the key difference is when hospice care is appropriate. So both palliative care and hospice are interdisciplinary types of care that focus on quality of life. But palliative care is really that extra layer of support at any time from the time of diagnosis and happen anywhere in the care system, like we talked about, whether it's in clinic, in a hospital, in some other care setting. Hospice is specifically for patients who are at the end of life. And there are different ways that one determines medical eligibility for hospice. But it's also an insurance benefit for comfort-focused care that's interdisciplinary, and I'll talk more in detail about what that means. And most often it's delivered at home. When I talk with people about whether or not hospice is appropriate for them, there are two pieces that I address. One is that medical eligibility. Do they sort of criteria for life expectancy of 6 months or less? And secondly, does it align their goals? And we'll talk about that here. Because whether or not it is appropriate really has to do with what your priorities are and what you want really at the very end. So as I said, it's an insurance benefit that covers interdisciplinary end-of-life care, most often at home. So people get regular visits from a nurse. The nurse is the team leader, really. Usually those visits happen weekly, maybe a little bit more depending on a person's needs. There's also a physician, comes typically every 2 weeks, a social worker, a chaplain or spiritual care provider. There's a care coordinator who typically does not make home visits but is available for calls. And then there's also a few hours of home care services. So unfortunately, hospice does not come with 24/7 care. A lot of the, hands-on care is still the responsibility of either family members or home attendants if somebody already has care. What they do is assess symptoms, provide medications, and guide their administration. So usually they'll leave medications for pain, anxiety, shortness of breath, constipation, that type of thing. In the home, just things that are common for people on hospice. If they're not necessary, then they just sit there and you don't use them. If a symptom does come up, then you don't have to go through the process of calling the clinic and waiting for a call back and then getting, a prescription sent to the pharmacy and prior authorization. And, now it's 3 days later and you're finally getting your medication. They have the medication for you. And then if you need something else for symptom management, then they'll actually deliver it usually same day. They can help people get different types of supplies, certain limited types of medical equipment. So unfortunately, they will not help somebody to get like a power wheelchair if they don't already have one. So sometimes I'll encourage somebody to wait until they do have that wheelchair to enroll in hospice if they're thinking about it. But they will provide things like a hospital bed or other types of care supplies if those are needed. Other thing that it comes with is a 24-hour hotline. So if something happens in the middle of the night and you aren't sure how to manage a particular symptom, there's always somebody who picks up the phone. In a true emergency, they can send a nurse out at any time to manage something. So it really becomes the holistic support team for the individual with ALS and for their families. There are a few goals of hospice, including number one, keeping people out of the hospital. So really keeping people at home or wherever they live. The hospice can be delivered in like a nursing home, something like that. They really prioritize controlling symptoms and comfort and dignity, as well as providing support to loved ones. Including sometimes bereavement support, or really not sometimes, bereavement support like it. There are some notable things that it doesn't provide, and this is where that alignment with comes in. So they don't cover your typical hospitalization. So if someone says, if I developed an infection, I'd want to go to, or, a fever, let's say, and a cough, I'd want to go to the hospital and get, a chest x-ray or a chest CT, and have a diagnostic workup and be treated with IV antibiotics, potentially be intubated if I needed to be. That is not the type of care that hospice provides. Usually hospice is really focused on comfort. So it's really for somebody who says, knowing that time is on the shorter side, I really want to just minimize medical interventions and kind of contact with the broader medical system. I want to focus on at home, being comfortable, and kind of allowing nature to take its course. So that's a significant thing that changes when somebody enrolls in hospice. And similarly, they don't typically cover ALS medications. So Riluzole and Radicava are typically medications that somebody would be stopping aside to hospice. Just a couple last thoughts on that are that, can be really helpful for people to have that resource to go to when they have reached that decision and when they have reached that point medically. Hospice is not necessarily this, 24-hour in the home support system, but they do really provide, I think, a lot of support for the right person. But for some people, that's not the decision that they make. It's also okay. It's still something to talk. So just some take-home points. I know we've covered a lot of ground and I talked really fast, so hopefully you have your questions ready. But palliative care provides extra support with physical and psychological symptom management, coping for people with ALS, as well as for their family or care partners, ideally spiritual support, and then a lot of support around decision-making that is aligned with your goals. It's most beneficial when it happens early and longitudinally and part of your care team. Supported communication and decision making can be difficult, right? Talking about the topics I've covered today hard, they're really heavy topics, but can also help to empower people with ALS and their family or care partners by making sure that you have the information that you want, that your wishes and hopes are known, and that you are getting the care that you do want and not the care you don't want. Advanced directives can be helpful to get your wishes in writing, right context, in whatever direction those wishes take you. And then hospice can be a good option for you who do want to minimize medical interventions in life. And I'd just like to thank the folks that I work with at Mount Sinai, and thank you all so much for your attention, and especially ALS United for having me to take questions.
Yes, thank you so much, Dr. Crooms. We are so happy to have you here and very grateful for all of your support today and the great information you provided. We have quite a few questions for you. The first question is how to get palliative care when nothing is working well for the patient.
Yeah, great question. Best way to find palliative care in the community. I think that's a little bit of a tough one, just because it varies so much. Many multidisciplinary ALS clinics are going to be affiliated with like a larger health system, and most health systems now do have palliative care. The Center to Advance Palliative Care it can also be a helpful resource for locating practice in your community. Primary care can make those referrals, that type of thing. And yes, insurance does cover palliative care.
Does a diagnosis of ALS automatically make you eligible for palliative care?
I would say yes. Yes, it does for palliative care, not necessarily for hospice, specifically, not until you sort of the medical criteria. But yes, for palliative care really should be any time from diagnosis. I will say that depending on the clinical setting for somebody, there is often a shortage of palliative care clinicians, just because there's unfortunately a lot of serious illness out there, and so sometimes it can be harder to get in to see somebody. Yes.
I really like the interdisciplinary approach of social work and primary care together. Thinking of the previous presentation, what do you do when you identify need for more ongoing psychotherapeutic support for a patient or family, for example, referral system, etc., and do you prescribe medications for depression and anxiety?
Yeah, great question. So I would say it really depends. We certainly have, I know Vane has kind of a list of like therapists that she might refer to if like more of a longitudinal, like regular psychotherapy would be helpful, which it is for a lot of people. And that's usually something that we do check in about. So I would say kind of exploring people's preferences around that is something that we do. It can certainly be difficult to access mental health services, unfortunately, as we know, in this country. Sometimes the way that people need to access it is going through their insurance to look for a list of covered providers, but we do usually provide a list as well. And then, yes, I do prescribe medications for depression and anxiety. When people are, if somebody's been on, multiple psychoactive medications for a long time, and or if there's a need for under most circumstances, like an antipsychotic or something like that. That's usually not me. That's usually when I would involve a psychiatrist. But absolutely, along with kind of talking about those coping strategies, accessing psychotherapy, and then also I do also prescribe antidepressants and anti-anxiety medications.
Thank you. What is the difference between a muscular neurologist versus other kinds of neurologists?
Yeah, great question. So neurology is sort of the umbrella for folks who deal with diseases of like the nervous system. Exclusive of psychiatry is a little bit of a used to be a lot more overlap than there is now. But brain, spinal cord, nerves, etc. So a neuromuscular neurologist specializes in the parts of the nervous system that are outside the brain and spinal cord, and that would include ALS specialists or most often neuromuscular neurologists.
And also a second part to that, is it typical to have both types of neurologists in an ALS team?
No, it's not. There are a handful of, maybe more than a handful at this point, of multidisciplinary ALS clinics that include a palliative neurologist. I'm a little bit unusual among palliative care physicians in that I am a neurologist. I did neurology residency prior to doing a one-year palliative care fellowship. Probably the specialization is something I should have touched on. So most palliative care clinicians, physicians are going to be internal medicine trained. So they might, for like primary care or inpatient hospital medicine, like more generalists who then specialize in palliative care. So I might have a little bit more of a deeper understanding of ALS than the average non-neurology palliative care clinician. Um, yeah.
In this summit, I attended the wheelchair assessment session. It came up that if someone is making a claim with insurance for a wheelchair, any request by a team for a patient to receive palliative care, claim code is the same as respite care, will be a red flag to the insurance company, and a claim to insurance for a wheelchair will be denied. If I'm understanding that correctly, who is usually responsible for discussing this situation with the patient, family, as the possibility of palliative hospice care is considered?
Mm, that's a good question. I actually have not ever encountered that. So I'm not sure. It's certainly true for hospice. So that's exactly where, if somebody is considering enrolling in hospice, and maybe they're like approaching readiness for a wheelchair, right? Like they've had a wheelchair assessment and they're just waiting on delivery or like insurance coverage, then I will encourage them to wait until that's true. That's true for both wheelchairs and non-invasive ventilators, because typically hospice will not initiate those things or insurance will deny them if somebody's in hospice, but they will not lose them just because they enrolled in hospice. So it's a good idea to kind of have those things lined up. Um, for palliative care, don't I don't know that that is true. It has never come up for any of my patients as far as I'm aware. But if it did come up, then I guess I would talk to probably the clinic coordinator as like as a first pass to kind of figure out, what is the what are the steps needed to sort out the situation, because certainly, unfortunately, that touches on a real issue, which is just the amount of administrative work that comes with an ALS diagnosis, and how much people have to advocate within the medical system, unfortunately.
We have about three more questions left that we have time to answer. Related for
I'd be
people
quick.
already with wheelchairs, it's my understanding that as long as a patient is using palliative care, maintenance or fixes for wheelchairs are not covered by insurance.
Yeah, so that would be again for hospice. I do think that that's true, that they won't do additional fixes. So again, it's like you want everything to be kind of teed up. And I see that, sorry, I'm also in looking at the Q&A here, and I see that the person who's asked this question said that the code for billing is the same for both palliative and hospice. I wish I had a better answer for you. It's not something that's come up in my practice. It really shouldn't be. The issue typically, and I think this is also something where one can clarify, like with the insurance, do like an appeal if absolutely necessary. For hospice, it would be a bigger issue where they just wouldn't do it. The main issue there is that hospice gets like a specific payment amount every day, regardless of what the type of care is the person is receiving. And so if the cost of care exceeds that amount, then they typically will not cover specific um, treatment in question. And so that is kind of where that issue comes from. Like I said, it hasn't really palliative care question. So I'm sorry. I will try to find out the answer to that question for you and let Donnie know.
Our last question, if one goes onto hospice, can one continue to pay for their ALS meds out of pocket?
Yes. Yes, I think so. It doesn't happen very often, but yeah, I think that would be, and I do also think that depending on what the situation is, it would be somewhat at the discretion of the hospice organization, whether or not, and depending on what the treatment was that you wanted to continue, whether or not they would accept the referral. I think probably for something like riluzole or radicava, they would, but for something like tracheostomy, typically they will not enroll somebody as a tracheostomy and uses a ventilator.
That concludes our session for today. Dr. Crooms, thank you again so much for helping us out today and sharing this wonderful information. And thank you everyone for attending our session. I would like for you all to hang around. Our next presentation is at 4:15. It is home accessibility, adapting your home to make it safe and accessible with our occupational therapist, Tejal. So we hope to see you all there, and thank you again for attending today. Take care.
And I will try to find out the answer because that is a really important question. So I'm sorry I
Yes,
don't have it.
thank you.